Okay, sternum. Sternum, it's easy to understand bone. It's easy to read bone. Let's go to the 3D model again. Okay, here is the sternum. It's the bone. It's in the front. It's a flat bone that is joining the costal cartilages on each side. It is consisting of further three parts. The part that is above, that is the manubrium part, then there is a sternum body of the, then the xiphoid process. Okay, let's go through the features one by one. Okay, this is the bone. I would advise you to actually go through this attachments. I will tell you again, but this is the bone that I would like you to go through that. Okay, the first part is Manubrium Sterni. This bone as a whole, it is, you can see I'm looking from the right end, it is convex on the anterior aspect. You can see from the anterior aspect, this will be the anterior aspect. So anterior aspect, it will be convex, and the posterior aspect, that will be concave. And it is also sometimes linked, give an example of a sword, like Manubrium is the handle and the blade is the body and the tip is the zipper process. Then let's talk about the manubrium part. This manubrium part, it's having two surfaces, anterior surface and posterior surface. The posterior surface is mostly concave on both directions, anteroposterior and right to left. Thus, this surface, it's a little difficult on the side to side on this way. Right to left, if you go, it is convex. You can see if we look in from the right side, this is the margin and this is the middle part. So it is convex. The margins are behind and the middle, and this part is anteriorly. So this is convex. But if you look at it, the from above downwards, it is either flat or a little concave. You can see it is not bulging in the forward direction. In this particular picture, you can see it's relatively straighter, but it may have a little curve. So from above downwards, it may be concave, but from the right to left in the transverse direction, it is convex forward. So this bone, when talking about this bone, you don't have to go for side identification because it's in the midline. So it will have two surfaces, the anterior and posterior surface. When talking about those, you have to tell about the convexity and concavity of these bones. The posterior surface is concave backwards, the anterior surface is convex when talking about right to left. This is concave when talking about above to down. Then it will have four borders from the upper margin, the lower margin, the right and left. Talking about the upper margin has these two notches. This notch for the clavicle, right clavicle, this notch for the left clavicle. So these are clavicular notches. The clavicles will make synovial joint with these points. And in this point, there is a notch that is present right here, that is also called suprasternal notch because it's present at the upper end of the sternum. It's called interclavicular notch because it's present between two clavicles. You can actually feel those right here. Go in the midline. In the midline, you will see above sternum. Here you will feel the head of the clavicle. Here you will feel the head of the clavicle. In between them, this is the suprasternal notch. On the side aspect, you will see the attachments of the ribs. These are called sternocostal joints or facet for the sternocostal joints. It's actually a misnomer because the joint is not made by the rib itself but made by the chondral cartilage of the ribs. So technically speaking, it's sternochondral joints, but it's usually called sternocostal joint. So don't get confused by that. And if you can look at this picture, you can see that the rib number 1 and half of the rib number 2 is getting attached to the manubrium. So that's it. That's about the and in the lower end, it is getting attached to the this body of the sternum through this joint. This is called Manubriosternal joint or angle of Louis. So angle of Louis, it is secondary cartilaginous joint. There are no two opinions about that. And this joint, it remains mobile till the late middle ages, till 40s and 50s up to 60s. And this joint actually bends a little when you inspire and will raise your lift. But as you grow older, this joint gradually ossifies. So that's about that. Now the questions that are usually asked are the its bony features. We just talked about anterior and posterior surfaces, the four borders, the upper borders, the two joint notches, the middle notch, and on the spec that is 1.5 rib gets attached. In between them, the intercostal muscles get attached, and the below there is secondary cartilaginous joint. Then you are asked about the bony attachments. In the anterior aspect, the bony attachment, the muscles of the anterior aspect, you read about them in the upper limb. Okay. You read about them in the upper limb. Let me go through the presentation. I think I have better pictures right there. I will go through them again. Yes, I have this picture. So in the anterior aspect, the muscle that are usually that are you going to be asked about are the this pectoral muscle. Pectoralis major muscle that is attached to the most of the anterior aspect of the shaft. This one, that is the pectoralis major muscle, and the upper aspect it will give attachment to the sternocleidomastoid. This muscle. Its name says sternum, clavicle, cleido, and mastoid parts of the skull. So sternocleidomastoid in the anterior aspect it gives attachment to that. And the posterior attachment, these are the two muscles that you're going to be concerned about. These are the sternohyoid and sternothyroid muscles. These are the pair of muscles that are going into the neck. And the below end they are going to attach to the sternum, and the upper end they are going to be hyoid bone, sternohyoid, sternothyroid, thyroid cartilage of larynx. And below you will see here these muscles, these are the muscles. Basically the innermost layer of intercostal muscle has a part that is called transversus thoracis. These are attached to the sternum here, and in the xiphisternum diaphragm is attached. So these are the muscles that you're going to be asked about. Now comes another question that is very commonly asked, actually very commonly asked. It's what structures are present at the level of angle of Louis. First thing and foremost thing is that you, in the person when standing in the anatomical position, you must know at what vertebral level does the angle of Louis lie. If you're in a person standing in anatomical position, if you draw a horizontal line, it will pass through the disc between the vertebra number 4 and 5. So that's a very important question that is usually asked. That is, it is like the angle of flow is present at the level of the disc between rib number 4 and 5. And the line that is joining, or the plane that is joining the sternal angle in front and the disc between, this is called transversus thoracis plane. Transverse thoracis plane usually called. So this is the plane that divides the mediastinum into the superior and first inferior part, or that is the most important question that actually fails you if you don't answer that question. Then there is the second rib. We saw in the model here. Okay, we saw in the model right here that the second rib, and this piece of information is again very important because when you counting the ribs in the clinical examination, that is the point that helps you identify the ribs. You find the jugular notch, go find the angle. You can actually very easily find your angle and the rib that is joined here. This is the second rib, and then you count from that third, fourth onwards. The ribs you will be able to count from there. So these two are things are unforgivable. The other things that are usually asked are arch of aorta. You can see the aorta has ascending part, the arch part, and the descending part. So the arch is above this, defined by this plane. The arch is above that, the ascending and descending are below that. Now this piece of information can be asked, can be mentioned in a variety of ways. So this, I'm repeating the same piece of information in a different ways, like the this angle of flow is the point of the highest most point of the ascending arch of aorta. It is the starting point of arch of aorta. It is the ending point of arch of aorta. It is the starting point of descending aorta. This is the same piece of information giving in a different ways. So it is also the same point where pulmonary artery bifurcates. It's the same point where trachea bifurcates into the two. It is the same part where the below there is a ligament. You can see this white point. If I remove the pointer here, at this point you can see this is the white point. So this is the ductus arteriosus. You will read about that in the embryological lectures in the next few days. So this is the point. So ductus arteriosus, ligamentum arteriosum is present right here, and this is the part, this is the line that defines the superior mediastinum above and inferior mediastinum below. And the arch of aorta is present, so cardiac plexus are present there. Superior vena cava receives azygous vein here. I think my list is much shorter than it needs to be, but because these are the things you can make the list, I will give a quick review. This is the point where second rib can be counted. This is the point that is at the level of disc between T4 and T5. This is the line that defines transversus thoracis plane. This is the point that defines the superior mediastinum from the inferior mediastinum. At this point, the arch of aorta is defined. So it is the ending point of ascending aorta. It is the starting point of arch of aorta. It is the ending point of arch of aorta. It is the Starting point of descending aorta. It is the point where bifurcation of pulmonary artery occurs. It is the point where bifurcation of trachea occurs. Ligamentum arteriosum is present at this point. Cardiac plexus is present at this point. Azygous vein drains into the superior vena cava at this point, and there may be actually other things that I may not be able to tell you. So these are the things that are usually asked in this regard. Regarding sternum, let's talk about mediastinum. Are you guys getting a good flow? Okay, let me. Can you guys hear me? Or is there interruption in the internet from my side? Okay, so these are the mostly things about Manubrium Sterni. And when talking about the body of the sternum, most these are the most things that are usually asked. Body of the sternum, that is again you will define the two surfaces and you will define the four borders. So its two surfaces will be the anterior one. The anterior surface is having a little convexity if you move from above downwards. From right to left aspect, it is usually does not have much prominence. As you can see, it is curved like a bow in the anterior aspect, convex anteriorly, concave posteriorly. On the anterior aspect, if you may be able to differentiate a little, like this horizontally, here like here like here, these are the horizontal ridges. They're not very visible visually, but they may be able to you may be able to feel them when you have the bone in your hand. But if you put a light on the other aspect, you will see this area, this area, this area. These are horizontal ridges that actually differentiate between the embryological different parts. What happens is that what happens is sorry what happens is that the sternum divides in pairs. So this part divides in pair, this part divides in pair, it later fuses in life. So these sternebri, or the original small segments from which the sternum originate, so the point of joining of the sternebri, it gives rise to these horizontal ridges. On the lateral aspect, on the margins and upper end, it gives attachment to half of rib number 2, rib number 3, rib number 4, 5, 6, and half of rib number 7. On the posterior aspect, it does not have many much features. It's usually concave and relatively smoother in nature. And then it comes with the upper and lower margin. The upper margin makes Manubriosternal joint. We talked about that in detail. It's symphysial or secondary cartilaginous joint. And then in the lower aspect, there is Xiphisternum, Manubriosternal and Xiphisternal joint. It is between these two, and there is a discrepancy between the works regarding its being primary cartilaginous in nature or secondary cartilaginous in nature. In the BD Shurasi, it's written primary cartilaginous, so my advice will be to follow that, because most of your examiners regarding osteology will be reading that book. So it's that, and this is the bone. It ossifies in your 40s roughly. So it's actually a complaint that people come with, that I have something pointing out here. It was not present before, but it is present now, because Xiphisternum was mobile and flexible. It did not become prominent as it ossifies in the 40s. So it becomes very prominent, and the person may start noticing it that it did not notice before. So, and below that there will be Xiphisternum. You will again give it small part. It may be bifid in some people, and it may be present or absent in some people. Superiorly, you will talk about joint and give attachment to the diaphragm. Basically, that's the most of it that's usually asked in this regard. What clinical aspects are usually asked in this scenario? Sternum. You're asked about sternal biopsy. Remember that as you grow older, the bone marrow, it sustains in the irregular and smaller and flat bones. It vanishes from your long bones. For a young person, 5 or 6 years old, the tibia and the fibula and the humerus and the radius, their shaft contain bone marrow. And in children, actually, we take bone marrow biopsies from there. But as you grow older, the bone marrows vanish from the shafts. The shafts become empty, and they're filled with, um, they're become filled with the fatty tissue. So the bone marrow that is present near the end of the bones, and they are present the irregular bones, and the sternum is one of the ideal bones for biopsy because it's just present below the surface. You can't miss it. You don't have to do some ultrasonography to find that bone, and it is not your, if you make a hole in the sternum, you don't have to go through a number of layers of the body wall to go through that. So in the adults, sternum is the one of the key bones, that is the bones of choice for the biopsy for the bone marrow. Pectus excavatum, pectus carinatum. If this is the bone marrow biopsy we talked about, and the reason behind is that it it is simple, easy to approach, and it contains the bone marrow till later in life. If the during ossification the sternum is sunken inwards, this is called pectus excavatum, like someone has excavated out of it. So it is called funnel chest, pectus excavatum, and it especially develops in those people that have respiratory distress early in their life. So a person had very long respiratory distress due to ongoing infection or something else, so the respiratory muscles, especially diaphragm, pulling it inwards again and again. In the young person, it pulls it inside, but congenitally malformed bones may also be present here. That is called pigeon chest, pectus carinatum. If you have seen a fowl or bird being cut, you can see that it's the heel, like kneel, it's present right here in the sternum. So it's present. If the sternum it's present uh, this like this. Prominent right here. This is called pectus carinatum. Carinatum means pigeon, the pigeon chest. So this is a picture of pectus excavatum, and excavatum it's more prominent. It may cause an effect on put, putting a pressure on the viscera inside. So this is a comparison between pectus excavatum and pectus carinatum. And ectopia cordis, you must have read about it in the embryological lecture carried out in your this week in your class. If the sternum that originally ossification centers on the different side, they join in the midline. If they did not join, then the gap remains. If the gap is very severe, then the viscera become outside, and the viscera that is present just behind the sternum is the heart. And if the heart is placed outside, this is called ectopia cordis. Heart is placed ectopically. And these are the minor issues of midline fusion. If the sternum, the two halves of the sternary, the ossification centers, they don't join in the midline, then such openings, such defects, such openings that may be present in the midline, such foramen, or maybe even the Ziffert process may be broken into two parts by fit Ziffert process. So these are uh, ossification defects. So that's all about sternum. So let me know if you want to discuss something before we move on to the last part of osteology, that is vertebra. You can put up your hand and ask the question through the microphone, or yes. Mm, Not really, and it does not actually matter because you have a lot of arteries already running outside. Actually, it does not matter. They may communicate one another, they may form anastomosis, but you already have your anterior intercostal vessels outside the sternum, in front of the sternum. So if there is any such connection may is made outside, then it does not matter. Small arteries. As far as aorta and other vessels are concerned, they are in the back, and they're pulled forward with the heart. That's another case, but usually the aorta is present behind the heart, so it does not isolatedly come forward. Okay, then let's move on to the vertebra. So vertebra are the bones that are making up your back. Okay, during surgery in the sternum, in the open cardiac surgeries, you just saw from the midline. You just go through the midline, break sternum in two halves, and open up the whole of the chest cavity like a book. The ribs will go this way, this way. The sternum is cut from the midline. and then the ribs with the sternum attached, it goes, the right goes there, the left goes there, and you approach the heart and open that. When you're done with the surgery, you bring both halves together, you staple the ends, and stapler or the other any method will allow the bones to remain close together till they are ossified, and the other layers are just sutured together also. नहीं बेटा, वो ध्यान से करते हैं तो सारी सर्जरी की आप इतनी सारी ट्रेनिंग किसी लिए लेते हैं? तो आर्चोफेटस के साथ बिल्कुल टच नहीं कर रहा, इसके थोड़ा सा पीछे है, यस इसके करीब है, बट दैट्स एक्चुअली व्हाट सर्जन्स लर्न इन सो मेनी इयर्स ऑफ देयर ट्रेनिंग. सो इसके बिल्कुल पीछे आर्चोफोटा है, लेकिन आर्चोफोटा के साथ ये एम्बेडेड नहीं है या फ्यूज नहीं है कि रिब काट दी, स्टर्नम काटा तो कट जाएगा. सो इफ यू गो केयरफुली एंड डोंट go deeper than you need to go, you don't damage this. आपकी सारे कैबेज सर्जरी जो आप बाईपास सर्जरीज आपकी होती हैं, तो ओपन हार्ट सर्जरीज ऐसी ही होती हैं, रिब को काटते हैं, दोनों साइड पे चली जाती हैं. इसके बिल्कुल पीछे ओटा है, यस यू आर राइट बिहाइंड द लोअर हाफ, बट यू आर केयरफुल इनफ, इट रिमेन्स ओके. Okay, let's talk about now the vertebra. Vertebra are the bones that make up your back or backbones, and it has to be too imperfect to affect that. Epictus excavatum or carinatum, it's very much pronounced and it may affect it. Um, a little malformation, they don't have much difference other than the aesthetic value. The person may seem not average person, but it has to be a major defect to cause imperfection to cause such an effect.